So good evening, all the aspirants present here. Today's topic is infectious diseases and tropical medicine. And the faculty that we have here is Dr. Anand Joshi, sir. He is a consultant, intensivist, and physician at Government Hospital, Hyderabad. Yes, sir, you can start. Thank you.
Good evening, everyone, and welcome to a second lecture for our series of lecture on topic of infectious disease and tropical infection. This is a part of our ongoing process from FIRST Academy for having teaching for the MRCP aspiring candidates. But I would put it in a different way that this is more of going through or brushing our basics of the medicine, and in a very interesting way, wherein we can see the different perspective, rather the practical perspective and the bedside application of all the theory which we have so far read. Now, the second topic which we are going to cover is a sepsis and septic shock. However, I was requested by the team that some of the new joinee would like to have a quick review of what we studied in our first talk. So in the first talk, we spoke about the medically relevant microbes and the antibiotic classification. We are infected by bacteria, virus, fungus, protozoals, and all other lot of microorganisms, out of which we focus this talk on the bacterial, virus, and the fungus. And all these things are classified under as microbials. So all the things which are acting against them will be antimicrobials. However, we need to differentiate that those acting against the bacterial are antibacterials, those acting against are antivirus, and those acting against fungus are antifungal. Now, this may find to be quite funny for people who are listening, but when you come into the practice and when you start giving say azithromycin or amoxicillin to all cough and cold, then that's where your application starts. So even though this looks like a stupid argument and thing to retreat it, but it is very important, I felt, that we should let people know or let the students know that antibacterial kills a bacteria, antivirus kills a virus, and not the antibacterial kills any viruses. We went through the basic structure of the bacteria. Why we need to know? Because we need to know, one is how these bacteria are going to invade us, and two, how at what point we can attack and destroy them. We spoke about how we can recognize the bacteria. We recognize the humans as a North Indians, South Indians. We go by their languages. In the similar way, we go by the color. So we in the similar way, we go by staining the bacteria, how they look like bacterial morphology, that they are round, they are rod, then how they reproduce, how they are resistant, and what food or oxygen they require. We also studied about how the bacterial virulence factors affect, and then we went through the common bacterias which, as per their classification, which infect us and cause the representative diseases. We went through gram positive, gram negative, and then the third was acid fast, and then we went through a rigid wall, thin wall, and the wall-less. Then we came up to what are antibacterials. We spoke about what are bacteriostatic, what are bactericidal, and then we spoke about and which part or the structure of the bacteria we target that makes antibacterials. And then we spoke in detail about all the antibiotics, what are the beta lactams, what are the no lactams, what are the protein synthetic inhibitors, and so on and so forth. This was a
இல்ல நான் ரொம்ப பிஸியா இருக்கேன்.
Right. This was a composite slide which I got it from internet, and we've been using it in my ICU. I love this poster which I took a big printout, and I always keep it in my ICU and in my clinic, just to give a idea about the range of organisms covered by different antibiotics. We also spoke about the drug resistance, how the drug resistance, what are the various mechanisms, why it is important. You will be seeing more and more drug resistance as you come into your practice. We spoke about different classification and what are the drugs that get resistant to these commonly occurring bacteria. Then we spoke about how we can prevent the bacterial infection in a specific situation by the use of vaccine. We also spoke about bacterial indications. Then we had a very brief overall view or classification of the viruses. This was nothing to remember about it, but to make us aware that the viruses are also classified. uh, we spoke a little bit in detail about the antivirals. We had covered HIV in the previous talk. And then we spoke a little bit on the overlapping hepatitis viruses and herpes viruses. Um, then we spoke about, as we have an antibacterial and we have the site of viruses, a site of bacteria, how they're targeted in a similar way. Viruses are very tricky organisms, so it's very hard to directly target the virus. So what we target is the interaction of this viron with our cells. So this is normal human cells, and this is how the viron enters. And then how we target these viruses from becoming ineffective. Sometimes we can kill them, sometimes we just have to make sure that they do not proliferate in our body. Then we had an overview of antiviral used in a herpes family, and then a timeline of how antivirals developed and what prophylaxis we take it. Then we spoke about fungal infection, what are the moles, specifically Aspergillus, Mucor, and then we spoke about the candidiasis. Um, Quick look on histoplasma, blastomycosis, and rest of them mainly affecting the immunosuppressed people. And then we came across these broad spectrum antifungals and their mechanism of action. We also spoke about what are the various antifungals, their classification, and a quick chart on antifungal. This is also one of my favorite posters, which I have put in, which I take a printout if I don't remember and try to refer them for a quick references. So the next one was we were supposed to talk was, which is today's topic, is sepsis, septic shock, and antibiotic adjuvant. Now, would like to know any questions from the previous talks, or anybody would like any to clarify any doubts. Anyone? No one? Right. So I'm just going to stop sharing and reshare the new topic. Is everyone able to see my slide? Everyone able to see my slide?
Yes, so the slides are visible, and also the aspirants can unmute themselves to answer the question, or they can also answer it in the chat box. Thank you.
Yeah, that would be a good one. bit of interaction is always good. So now, last topic, we found out what are the living species that interact with our body, and we classify them as bacteria, fungus, and viruses. Now, when these organisms enter into our body, the body reacts, and the manifestation of this interaction um, occurs by the way that the body will try to defend itself. Now, this is very important to understand that for thousands of years, this interaction between various organisms have been happening, and then our body also reacts by producing an inflammation. The purpose of this inflammation is, and increasing the white cell count, is to trap these organisms and kill them and throw them out of the body. Now, this has been happening for ages, for thousands and thousands of years, and has been a protective mechanism for us, because if this was not there, then our human life would have got perished, and the human development could have never gone up. Now, this interaction manifests in a different form in our body, and interaction, we call it as a sepsis. Now, as the fire or the inflammation goes up, there is also a check on that, and this check is called as anti-inflammatory effect. So there is a pro-inflammatory effect and there is an anti-inflammatory effect that keeps a check on this inflammation so that it doesn't go out of the control. And this is done by the anti-inflammatory, which will counteract the pro-inflammatory. And when the disbalance or the dysregulation occurs, the person end up in a shock-like state or a multi-organ failure-like state, and this we call it as a
Excuse me,
septic
sir.
shock. Yes.
Sorry to disturb you, but the slides aren't moving.
No, because I haven't moved it. I know.
Oh, sir. Thank you.
Yeah, so I wanted to describe it, what a sepsis and what a septic shock is. So that's where the topic comes in. So now, having known that this is a balance between the inflammation and in a balance of inflammation, that is, we have a pro-inflammatory state and there is a anti-inflammatory state, and we always felt that this was an advantageous, till we started realizing in some portion, or rather majority of the portion, people are dying. The people are dying because of this interaction which is happening in our body. All the while we thought that everything was driven by the organism which is entering into a body, but no, organism was just a trigger, and then whatever happens is mainly as a reaction of the body to the invading organisms. And when this happened, it need to be defined, and at currently what we define it as a sepsis, as a life-threatening acute organ dysfunction due to a dysregulated response to the infection. So when the organism enters into your body, it is called as infection. But when this infection is responded by our body, again, we call it as an inflammation. But when this becomes dysregulated, as I said, with the pro-inflammation, it has to be a controlled way. It becomes anti-inflammation should also come up, and if this dysregulation leads to an acute organ dysfunction, we call it as a sepsis. Now, this definition which we are talking about, or we are speaking about, was not easy to form. It's been a long since the advent of discovery of various antibiotics. People had wanted to define it. Not until 1992, some people got together and started analyzing this inflammatory response, and this overburdened inflammatory response. They came up with some criteria which is called as SIRS or SIRS criteria, which we are going to see next. And over from 1992 till 3 decades now, we have come to, though I would not say that this is a perfect definition, but this is somewhat near definition. Currently, we call it as a life-threatening acute organ dysfunction due to dysregulated host response to the infection. This is very important. It's a host response, and SIRS is no longer included in current definition. Why is it so? We will see now. So it's very important for us, even as a doctors, even as an MRCP candidates, or even as a general medicine, whatever you are doing, you need to understand few terminologies, because when you are going to face any person with an infection, you are going to come across these terminologies while discussing or while reading to the various books. The first terminology is the systemic inflammatory response syndrome. As I said, these are the responses of the body, of a normal human being to the invading infection. So you get a temperature, either hyper or hypothermia, you get increase in the heart rate, you increase respiratory rate, or PaCO2 or carbon dioxide washout, you get high white cell or the low white cell count, or bands more than 10%. Now, this is the host response. Now, what would be the sepsis? This is a systemic inflammatory response to the infection. Then we had severe sepsis, which been described. It is described as when the sepsis becomes severe, that includes an organ dysfunction secondary to sepsis, we call it as a severe sepsis. And then when do we call it as a septic shock? In septic shock, it is important that there is a hypotension that is secondary to the sepsis, and that is resistant to adequate fluid administration and is associated with the evidence of hypoperfusion. So this becomes a very important thing. You cannot blanketly give a number to that, or less than 90 systolic blood pressure is called as septic shock. It used to be this kind of fixed number, but now it is no longer, because those people who are chronically hypertensive, say they are like 160, 170, 180, and then they drop down to 110 or 100. So systolic is still not below 90. However, they are showing all signs of hypoperfusion and organ dysfunction. And in that case, that would be considered as a septic shock. All clear so far? So let's see how this sepsis definition involved. Now, this may not be very interesting or relevant to many people, but it's always good to know how the things evolved, because sometimes in examination, if you are trying to define yourself or defend yourself, you can use these things. So Louis Pasteur gives a scientific credence to a germ theory in 1860s, and then in 1800, Robert Koch was the one who started postulating Koch's postulate. All these people did use some kind of SIRS response component to justify their discovery. Slowly and steadily, not till 1992, when the first definition by Robert Bone came up for sepsis, and then started the whole roller coaster of everybody focusing on it, till a society was formed, which was termed as Surviving Sepsis Campaign. And in that Surviving Sepsis Campaign, all the ICU, all the infectious, all the CDC people came together and started defining the sepsis. Now, why you need to define a sepsis? You need to define a sepsis, one, for the research purpose, to gather the cohort of the people, and also to target a specific protocol or therapy for it. For example, if you come across a heart attack, you get a myocardial infarction, then there is a protocol. You need to go and do an angiogram to open up an artery, whether you do it a bypass, you do put in a stent, So that follows, and hence we need to define a, cardiac myocardial infarction. In the same way is the brain stroke. So in the same way, in the same lines, sepsis definition became an important. So as mentioned before, it started off as a SIRS, CARS, and MARS response. That is, a pro-inflammatory response was called as SIRS response. Anti-inflammatory response was counter-regulatory response, and the mix was called as Mars response. And then these body response was in response to the invading organisms. Now, the current definition of sepsis has evolved. Initially, there were too many components, there were too many SIRS components, so that was coming up as a sepsis 2 definition, wherein the whole sepsis was divided into a simple infection, sepsis, severe sepsis, and septic shock. So this was called a sepsis 2 definition, in which we had a SIRS criteria, and then we had sepsis with organ failure, and then septic shock as a refractory hypotension. Now, this was creating a bit more confusion, so they decided to come up with a more simpler infection, a simpler definition, which we call it as a sepsis 3, in which instead of 3 criteria categories, they have got only 2 categories. One is sepsis and septic shock, and they have clearly defined that infection and its manifestation that may include hypotension, hyperlactatemia, or vasopressors, and septic shock is a non-responsive or persistent hypotension with hyperlactatemia and vasopressor. Now, if you see on the right side, you see the sepsis 1 and 2 definition, where there is a suspected infection and SIRS response. In sepsis 3, they have kept the infection indicator or suspected infection. However, they have added 2 tools, which we call it as a SOFA scoring system, which will help us to identify whether the patient is responding to that organism in terms of in terms of SIRS response. To be very honest, this is similar to SIRS response, but more component are getting involved, and they put it as a scoring system. Why again they wanted to change this definition? Because based on this definition, if the patient is having a sepsis, its mortality was found to be almost 10%. But when the patient went from sepsis to septic shock, the mortality increases to 40%. So this is where your bedside application comes in. You would always think that why we need to do so many uh, of churning of the brain to remember, and why we need to define these kind of sepsis and differentiate with a septic shock. Because if you don't differentiate, then the aggression with which, the sensitivity with which you need to approach, the time sensitivity with which you need to approach the prognosis, everything changes. So the people that are 40%, so a disease where with the best of the effort also, if there are 40% chance that the person will die, is really serious as compared to one which has a 10% to die. Now, as I said, the important component in this sepsis 3 definition was not only the infection, but the response of the body to the infection. Now, initially, as I said, sepsis 1 and 2, they were talking about a SIRS or SIRS criteria. However, they were not enough. So they introduced a major more organ dysfunction system, because now it was known that simple sepsis and a septic shock. So in the septic shock, there has to be a organ dysfunction, because that is how a dysregulated immune response is manifested. So how to recognize this organ failure? Now there used to be a very long method that was called as Apache scoring. So it was from Apache 1 to Apache 4. But to do that practically, like there were like 12 variables, and then there was 0 to 71 was a scoring, and it was a very tedious. Now if you look at this evolution of Apache score, look at the 1991 Apache 3 scoring. There was a scoring from 0 to 300 with a 16 variable. So while the computers could do that, but it was never a quick, you cannot have a quick recognition of this kind of thing. So it was quite impractical. So they came up with sequential organ failure assessment. They called it as a SOFA score, where they involved 6 organs, and then they graded the organ dysfunction, and it became much better than going with the Apache scoring. So this is the a sequential organ or a SOFA scoring, where you have a respiration, you have a coagulation, you have a liver, heart, brain, and kidney. So basically, if you want to remember, you can remember it as a brain, lung, liver, kidneys, and coagulation system. And all these SOFA scoring would be scored from 0 to 4, and the more the score, the bad the outcome is. Now, again, there were how many? 1, 2, 3, 4, 5, 6 components in this. And this was also getting more tedious. So they came up with more shorter form of this, which they call it as a Q SOFA score or a quick SOFA score, in which they included only 3 components. So these 3 components was the blood pressure, altered mental status, and tachypnea. So basically, a brain, heart, and lung. And score of more than equal to 2 suggests that this patient is having a sepsis or septic shock and likely to have a poor outcome. So these patients should be transferred to the intensive care. Now remember, this Q SOFA scores application was more for people outside the ICU. Those people who were already sick was obvious. You don't sit there and start calculating Q SOFA score. These were the subtle things which needed to be picked up by the nurse or junior registrar. So when you guys, suppose you get any job in UK and you are a medical SHO, then you will be expected to pick up these early signs, and you can quote as a Q SOFA and then alert your attending or senior, and or transfer this patient to the intensive care. So this is where your Q SOFA scoring comes to your rescue. So again, just the same thing, sepsis and the septic shock definition. So now currently, if somebody asks you what's the evolution of sepsis, so there are only 2 things there in sepsis 3 definition. One is sepsis and another is septic shock, where sepsis, it's a life-threatening organ dysfunction due to dysregulated host response, and septic shock is a subset where there is a circulatory and cellular/metabolic dysfunction with high risk of mortality. So this is what all the definition comes into it. Now, I started off with initially with my first talk, where we say that the invading either a bacteria or a fungus or a parasite or a virus or any other protozoal would would stimulate or trigger a intense SIRS response, and that interaction we call it as a sepsis. So there are 2 components here: one is the infection and one is a SIRS response. However, over the period of time, we realized that it is not only just an invading bacteremia. This dysregulation of the pro and anti-inflammation can also occur in certain other conditions. And these conditions primarily we came across when there were pancreatitis, when there were burns, or where there were trauma, or any some kind of poisoning. So it becomes a very imperative that those people who come in with these things may also manifest the all the criteria or all the components of SARS body's response or inflammatory response, and these were called as infection mimics. Why it is important? It is need to be mindful that these things historically, if they are there, then it's not that these things will be treated with antibiotics. These needs to be carefully weeded out, that if there is no infection, then these are the causes of this SIRS response, and we don't have to use any antibiotics. So this is the importance of this slide, and to differentiate between an infection, a SARS response, and a sepsis. This, I love this slide because it just gives us what what we have spoken so far. So there is an insult, and then there is a trigger, and this trigger are the kind of exotoxin or the structural components of the bacteria. See, these bacteria sometimes secrete some toxins, or this bacteria has its own components, particularly gram neck, the classic example, or what we call the classic, again, the classic example would be the wall of gram negative bacteria which has got a lipopolysaccharide. So that has been found to be trigger, which are sensed by our immune system to blow out the inflammatory response. And in this inflammatory response, like these sensors are these plasma proteins, blood, lymphatic cells, and vascular tissue. Now these inflammatory response, they occur via mediators, and when these mediators come in, there is a tsunami of cytokines, chemokines, and endothelial stress response, and then it manifests itself. How does it manifest? It manifests as a cell dysfunction, it manifestation as a cardiac dysfunction, it manifests as a peripheral vascular vasodilatation, and get into a refractory hypotension or cytokine storm or order dysfunction or tissue injury. And hence the outcome we get it either with the sepsis or septic shock, and ultimately multi-organ failure and death. The small green things which are there, these are the futuristic targets where we can use it to block this SERC response and try to decrease the mortality rate. However, they are all still in an experimental. The purpose of this slide was to give you a perspective that how bacteria, its components, come and create a septic shock and multi-organ failure. So sepsis pathogenesis, as I've been repeatedly saying, that it's an unbalanced immune response where there are certain trigger factors which causes a procoagulation state, microvascular thrombosis. At the same time, the inflammatory mediators would cause a vasodilatation, reactive oxygen species, and capillary leak. This is a very nice cartoon which shows that how this is not a one-way traffic. It is a circular chain which keeps on triggering each other, where an excessive inflammation would end up with a microvascular injury, and that would cause an impaired immunity. So we have an intense immunity to start with. Over the period of time, how this immunity becomes paralyzed and gets into a organ failure state, which is manifest in a different way. So for example, in the brain, it manifests as an encephalopathy or delirium. In lungs, as a respiratory failure or ARDS. We have an acute kidney injury. Cardiovascularly, we have shock, cardiomyopathy, we have acute liver injury, and in hematologically, we have clotting, bleeding, or DIC. Now, all these things are triggered. If you remember, we spoke about the virulence factor of bacteria in our previous class, or in the revision we saw. These virulence play a very, very important role. So not only on the bacteria side it comes at the virulence factor, but on the host side, our immunogenicity, how good our immunity is, how bad the immunity is, how whether this we've been exposed to this kind of antigens before or not, they all play an important role. And these are called as pathogen modifiable modifying factors. Why? Because these are the components which can be targeted, and we can use medicines and drugs to block these virulent factors, or on the host side, our response factors, and try to bring down our mortality. Now, a bit of an epidemiology why we need to worry about sepsis, septic shock. It has been clearly been noted that we know that it's an organ dysfunction, and the mortality is directly proportional to the number of organs involved. Somebody is encephalopathic with poor heart function, is respiratory distress and ARDS, and got a kidney failure. You cannot come go and tell these people or family that, oh, everything is fine, they will be good. The kidney specialist may say, oh, my kidney is good. The heart specialist will say, oh, my heart is going is stable. The brain fellow will say, oh, everything is good. No. But as a general medicine, as a physician, or as an ICU specialist, when you speak, you cannot talk as of an individual organ. You have to prognosticate, and it is very statistically very clear, the more the organ involved, the bad the outcome is. You can see that mortality crosses 60%. Over the period of time, the incidence of sepsis, as you can see, has gone up, and as the incidence of sepsis and severe sepsis has gone, you can see the lower graph, the mortality has also been high. Now, we there has been plenty of interventions over last 3 decades, and the graph which you're seeing for the mortality of the sepsis, and on the right side, after the advent of ICUs and critical care people and intensivist involvement and some kind of disciplinary approach in these patients, we've been able to control the mortality. However, there is still a long way to go. Again, this is an epidemiological data which says that, as the top one says, that mortality is also proportional to the age of the patients. For in-hospital mortality, people with more than 85 years of age, sepsis, septic shock, they are likely to die irrespective of what the infection or what the cause is. Urinary tract infection seems to be one of the very important component, which again, age wise, for the elderly people, it is more of a urinary tract infection that is likely to kill, followed by pneumonia, and then followed by other infections. Bacteria, the bottom graph, still holds the top position for killing the people. And again, bacterial infection in an elderly would be a bad prognosis. So if you want to combine all the three graphs, an elderly person coming with a urinary tract infection or a pyelonephritis or UTI, secondary to some enterococcus, enterobacter, or gram positive, gram negative, is likely to die, much likely to die as compared to the younger counterpart. Right. So, anyone, any questions so far? No? Shall we move? Right. So let's have a quick look at about how does this um, sepsis septic shock patient come and how I would evaluate. Now, as I said, it's an inflammatory response and trigger. So obviously, all the SIRS criteria would be there. However, it's not a same response for every bacteria, every virus, or every fungus. There is for septic shock. Why we are so much confused about the thing. We are very clear that if there is a stroke, brain stroke, then we know the person comes with either altered sensorium or focal deficit. If you have a heart attack, you know that the person coming with chest pain and sweating and hypotension. However, there is not a specific organ system or one organ which is involved, and there is no sequence that this organ will be involving first, other organ will be involving second in case of sepsis septic shock. Hence, this concludes that there will be a heterogeneous presentation, and it varies widely based on where the infection is, what pathogen is, which organ has been involved before, what is a baseline health. For example, some people who are diabetic, who've got a diabetic nephropathy to start with, and then they get a bacterial pneumonia. So they will come with a worsening of the renal failure. So with some breathlessness, which might be because of the water retention. So it becomes a complex. So we don't know where the thing started. So this kind of heterogeneous presentation is very common for sepsis septic shock. However, some general signs will be there, and these are the signs which we spoke about in our SIRS criteria. Sometimes site-specific symptoms will be there, say cough, dysuria, erythema, and there will be an organ dysfunction symptoms. There there are a lot of challenges in this recognition because of heterogeneous, and many a times they are masked by the medications. For example, you may not get a tachycardia for a person who is on a beta blocker, so that would be a curveball for you. And probably it becomes a very important in this kind of situation that you have a very high level of suspicion, and for that these kind of screening tools have been made, which we spoke about it, like QSOFA scores, where you have an altered mentation, hypotension, or tachypnea there. This should be supplemented by your lab finding, where you have a hematological or white cell response, or sometimes they may just come as an uncontrolled sugar, elevated creatinine or lactate, depending upon which organs are involved. So the evaluation should be focused in trying to find out what would be the infectious site. For that, there are various ways to do it. You do it clinically, then you go for radiology, then you take blood cultures, and antigen testing, PCR panel, and so on and so forth. The second important would be what organ dysfunction or organ perfusion you got. And the most common thing which we recommend at this moment laboratorically are the lactate measurement. And clinically, we measure it with a touching the patient. So touching the patient, just doing a phone call and looking at the patient doesn't work. You go and touch the patient. Patient is cold, patient is hot. You look for the capillary refill time, and then you look at the lactate, and then you put everything in perspective. So to help us to evaluate or to help us to recognize this, various screening tools been devised. The most famous we spoke about was QSOFA, which is the current recommendation. However, even though people say that SIRS response should not be used, but I still feel that SIRS response is still one of the important and the best. Knowingly, unknowingly, we still use those responses. And then there are different other ways, warning scores, like national early warning scores and modified early warning score. They are particularly used by the nursing staff to alert the doctor that this patient might be having sepsis. Now, as I said, as with myocardial infarction and stroke, Timely early intervention has clearly shown to improve the mortality. If you delay it, then the percentage or the likelihood of the patient dying goes up. There are few things that has been established that started off that these 2 or 3 or 4 steps, if we do, the patient is likely to survive. And these are an established core treatment, that is source control, antibiotic, resuscitation, and supportive care. After that, and this has brought the mortality down. Now, after that, we've been various agents which have come and gone. And in all these last 3 decades, steroids were the very favorite. So initially they said give steroid, then they said don't give steroid, then they give steroid, then they don't give steroid, where the debate is still never ending. The next one was somewhere in between, a Zygris, which was an expensive product and which is now off the market. Nobody uses it. Now, the other one was whether to give a tight glycemic control. They said now you can have a loose glycemic control. It doesn't matter. All these things have gone. Immunonutrition was another fashion. They said if you stimulate and you boost to the immunity with the nutrition, probably the mortality comes down. Now, again, that is also in question mark. There are few other research molecules which have been tried. Some are failed, some are tested, some are still in the testing zone. However, these 4 things have not changed. One, source control of the infection. 2, antibiotics. 3, bit of a faster resuscitation. And 4, better supportive care. In general, the process of care has improved, and hence our mortality is better than as compared to 3 decades, but still there is a way to go. So the important factors I'm going to talk, which are very relevant and which are now an established one. I'm not going to touch any of the controversial or the controversial topics, or I'm not going to talk about what are the ambiguous things which we can use, which we cannot. If you get a patient of sepsis septic shock, you should definitely do these things minimum. If you do these things minimum, rest of them, whether you do or not, is irrelevant, because their contribution in improving the mortality is questionable. So the first thing in this series is an infection control. So it's very important for you to know where the infection is and whether you need to target that infection and have any kind of surgical intervention, particularly if there is an abscess, if there is an appendicitis, whether there is any requirement of drainage, there is an empyema, you need to remove that. Unless and until it is drained, this is not going to help. Many a times for, say, a bad pyelonephritis, you have to go for a nephrectomy. Otherwise, the patient will not survive. And these source control is a very, very time sensitive. Now, while you are doing the source control, it is important to promptly introduce antibacterial or antimicrobial. If you're very sure this is a fungal infection, and get the antifungal first. If you're not sure what is that, you can shoot all the three: antibacterial, antiviral, antifungal. However, these needs to be revised as the cultures comes in. So to start an antibiotic therapy as early as possible. The initial antibiotic therapy is often empirical and based on some suspected site, local epidemiology, or a risk factors for the resistance. And then later, revisiting this antibiotic therapy to narrow down as the diagnostic information becomes available becomes an important role. The second in the line for sepsis, particularly in septic shock, is the restoration of the perfusion. Remember, there is an organ dysfunction happening because the perfusion or the blood circulation to that organ has gone down. It has another involvement and disadvantage is that even if you give antibiotic, it's not going to reach to that organ unless the organ is perfused. The first in this therapy for perfusion is to maintaining or bringing up the blood pressure. Now, how do you do that? The first thing you do is give an initial fluid bolus. Which fluid you want to give? You can give any kind of fluid. There is no specific preference of one fluid over another, but if you have a choice, if you have got no other choice, you can always give any fluid. But if you got a choice, a balanced solution like Ringer lactate will be preferred over a normal saline. But if you don't have a balanced solution, doesn't matter. You can always give a saline. Whether the colloids like albumin is better, it has been established that there is no superiority of any colloid over this balanced solution for the resuscitation of a septic shock. It's a very, very well established in the trial. Now, why 30 mil per kilo? Do we need to fix this 30 mil per kilo? Not at all. This was an average number which was created from huge thousands and thousands of patients that were retrospectively evaluated. So the more and more data now it's coming in, it's a personalized approach based on the dynamic physiological measures like a stroke volume, passive resiliency test, using an ultrasound to look for the IVC collapse. These are better instead of giving a blinded 30 ml per kilo. The simple thing is somebody has got a very bad cardiomyopathy, comes in sepsis, septic shock. If you try to flood him, then he may go in a overburden. However, it shouldn't be assumed, again, it shouldn't be assumed here that just because the patient has got a poor LV function, I will just give 5 mil per kilo, I will give some 500 mils and sit tight. No, don't do that. Use the dynamic physiological measure in these patients also and try to optimally give the fluid as much as possible, because you need to fill up your intravascular status and then try to increase the blood pressure. Many a times you'll be surprised to see that just by giving some fluid, even if it's a very poor cardiac function, they will start improving. Their cardiac stroke volume goes up, their venous return comes up, and so you may not require much of the ionotropes or vasopressor. So fluid resuscitation is important. Do not try to use vasopressors without giving any adequate fluid resuscitation, please. So that is very important. But otherwise, you are trying to squeeze by using vasopressors, noradrenaline, vasopressin, an empty vessel, and that might be more harmful than any useful. So keep the things in mind that fluid resuscitation is the first. Concomitantly or followed by, you should use the vasopressor therapy, and for that noradrenaline is the first line of thing. The targeted mean arterial pressure at this moment, the magic number is 65. However, if the patient is very elderly, say it's like 80, 90-year-old, then you can try to maintain it between 60 to 65. However, the magic number as of now is still 65 millimeters of mercury across the population, across the age. Going higher up, going lower up, it's a still controversial thing. Some people say logically those who are hypertensive, you need to go up, but we never know. We don't have any specific number. There have been studies where they have looked for keeping a map of 65, 75, 85 and try to look for the outcome. Yes, there are drawbacks to those trials. However, as of now, as we speak, the magic number is still 65. Now, you have gone the kept the things up to 65, you have given the fluid, but what are any other laboratory, any other method to understand whether these targets are adequate? There are two things that have been recommended. One, look for a capillary filling. Go to the patient, touch the patient, look at its hand, look at his leg, press it, look how soon that redness comes in, and that if it's less than 3 seconds, that's good. More than 3 seconds, that's bad. So that's one capillary filling. The second one is a lactate level. So if the lactates are high, here the number is more than 4 milligram per deciliter, then you got a problem there. Always remember that high lactate in this kind of situation may not be always because of the hypoperfusion. If you come across something which is not fitting, there is no lactic acidosis, only lactate is high, patient is good, then look for other causes of lactatemia. Try to understand that lactatemia is different than lactic acidosis. So when you're looking just as a lactate, be careful in interpretation. So antibiotics, infection control, fluid resuscitation, and vasotherapy. If you do these four things, then you have completed all the definite things which are required to save the patient. So this would nearly say, you can say that, okay, I've done everything what a patient needs to be done. Now beyond this, what are the problems, what are the things which you can use? There are not many which are available for us, and they have all their controversies associated. They are not antimicrobial things, and these are called as adjuvant therapies. The most famous, most common you will come across, bump into, are the steroids. Now the steroids came into the picture because initially it was thought that it was all inflammation, it was all fire, 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 fire. So let's give anti-inflammatory. So it's a potent inflammatory, anti-inflammatory were steroids. They inhibit the leukocytes, improve hemodynamic and organ function. That was the one. Historically, um, historically in the sense in early 80s, the people started using high dose methylprednisolone. However, later they realized that yes, it did improve initially, but the people were still dying because now they were becoming immunosuppressed. Now when they were entering into the immunosuppressed, then they started dying. So the high dose went off quickly off the shelf, that no, we are doing more harm. And this was replaced by low dose hydrocortisone. Now, this stems from various studies which showed that there is an relative adrenal insufficiency for a given stress response, and hence the patient becomes hypotensive. So, giving them, supplementing them with a low dose steroid, that is a hydrocortisone in particular, would be good. Why hydrocortisone? Because it has got an glucocorticoid activity and a mineralocorticoid activity. Mineralocorticoid activity will be helpful in restoring your blood pressure, and glucocorticoid activity would be helpful in anti-inflammatory states. And hence, giving 200 to 300 milligram per day would be helpful. Now so far it's been multiple time challenged. The last study was the non-inferiority study, wherein they said that you can give hydrocortisone, it's not going to be harmful. So they showed that the harm caused by this low dose was very less as compared to the high dose, and hence it to be accepted. So current guidelines suggest to give the 200 milligram per day of hydrocortisone to whom? In the patient who has got septic shock. That is, we have given 30 ml per kilo of fluid. The patient is still hypotensive. The patient, we have started on noradrenaline, and noradrenaline somewhere sitting between 0.25 microgram per kg per minute to 0.5, then you should be adding. Now, recently there has been various subset of the studies wherein the people saw the use of hydrocortisone in community acquired pneumonia. We have seen before that sepsis can cause with a wide variety of things. In that subset, they found out in community acquired pneumonia, early steroids, that if you give them, then probably it would decrease the treatment failure, ICU stay, and mortality. So as of now, if somebody asks what is the evidence, you can give hydrocortisone 200 milligram per day for patients who's got a community acquired pneumonia. The second good evidence is in the bacterial meningitis, where you give dexamethasone in particular. Here, remember, we don't need much of a melanocorticoid activity, and we need somebody who can cross the blood-brain barrier, and that would be a dexamethasone. So bacterial meningitis you can use. So steroid does show some promise in specific hyperinflammatory scenario, but still it is an it is its use, blanket use, high dose use is still controversial and better to be avoided. The next came in was the blood purification. They were so the whole concept behind this was, can we dialyze all these inflammatory mediators and do complete removal of the plasma and give them a new plasma? What will happen? In pursuit of that, there were few techniques. One technique was high volume hemofiltration, where you filter, you put the person on a dialysis and filter its blood so fast with a high volume that we expect that all the inflammatory cytokines will come out. The problem was pro and anti-inflammatory both were getting dialyzed. The second came whether that we can use some special material uh, that will absorb all the cytokines and all other toxic things. So extracorporeal cytokine heme adsorption and endotoxin heme adsorption was introduced. But then again, good cytokines, bad cytokines, both started getting heme absorption. So the patient's outcome didn't change. Then they decided, let us do a hybrid model. One is a heme adsorption and high volume filtration. So it is called as CPFA, and that also didn't work out. So all these evidence, most of them, they couldn't help to improve the mortality. Secondly, while we are giving antibiotics to these antibacterial people for to counter the bacteria, they were also getting dialyzed. So at the end of the day, what we were getting is all the inflammatory mediators are gone, bacteria are not dialyzed, and all the antibiotic is gone. So it was like a no-win situation, and hence the evidence for the blood purification still remains controversial, and they are not routinely advised as per the guidelines. The third one was an immunoglobulins. Now, this was a very interesting thing, that particularly in the cases like toxic shock syndrome, staphylococcus and streptococcal toxic shock syndrome, where the trigger is not the bacteria, but the endotoxin which is released. Now, these toxins can get neutralized by giving a high dose of IVIG. And this evidence suggests that in those particular cases, it was a very game-changing and a life-saving procedure. So this was one condition. The second condition was those people who had low immunoglobulin levels. So there are few conditions which are congenital, some are acquired, where you have low immunoglobulin productions. They are immunosuppressed people. They were also benefit. So rest of all the situations or conditions, these immunoglobulins didn't show any benefit. And even in meta-analysis and SBITS trials, there were no 28-day mortality benefit except these two conditions. So the role remains unclear. However, if you come across toxin-related staphylococcus or streptococcus, you are allowed, as per current guidelines, to give IVIG. Or if you know, or if you establish that this patient has got an immune paralysis, then you are allowed to do IVIG, and this can be a game changing for those patients. There have been different other things. The so there are four major ones where the GM-CSF, especially those who came with white cell counts which were less than 4,000, Does granulocyte stimulating hormone would help? No, it didn't help. Use of interleukin 7 didn't help. Anti-PD-1 phosphodiesterase 1 antibodies didn't work, and interferon gamma didn't work. So these agents, even though theoretical promise in reversing immunosuppressions, but clinically the evidences were largely conclusive, and at this moment they are not recommended. So concluding, we've got a sepsis, which is a life-threatening acute organ dysfunction due to dysregulated host immune response. It is a very complex situation because of the variety of infection we get, variety of site they enter, variety of organ dysfunction they involve. The current management clearly focuses on controlling the infection. You remove the abscesses, give antibiotics, and establish an perfusion and try to save the organ. Yes, there are a lot of future directions to decrease the mortality, but at this moment, it still stands high. And of course, we are better than what we were in 1980s and 1990s. We still way to go, but following these simple things would be beneficial. So that concludes my today's topic, and I'm happy to take the questions.
Hello, sir.
Yes.
Sir, good evening.
Good evening.
So, sir, my question would be when to add antifungals, and do we need to add it, because in sepsis antibiotics would be going on for a long time. So when to add antifungals in this?
Very good question, actually. So yes, you gave partial answer to the question. One, you need to understand that body's immune response is very, very robust, and of all the three, virus, bacteria, and fungus, bacteria are the strongest one to enter, right? Fungus are the relatively weaker thing. So if funguses are weaker for a normal person, then they become strong only when the normal person's host immune response is weak. What are the situation where you will have a weak immune responses? One, either they are congenital or they are acquired. So congenitally weak immune responses such as immunodeficiency, whether they are congenital immunodeficiency or immunoparesis in a long-standing diabetes situation, then these people who are coming with sepsis septic shock, you would start thinking of giving a fungal. Second thing will the acquired one. Now, what are the acquired ones, you will say? So acquired ones are the disease specific. What are the disease specific acquired? You said that an HIV, you can have it as a patient who are on steroids or the glucocorticoids patients. Those things you can start thinking beyond the bacteria. Third thing would be those patients who have been in hospital for long period of time, particularly on a broad spectrum antibiotic. You will find this very common in those patients who are on that, or those patients who have been visiting the hospital very, very, very commonly and having multiple antibiotics. So you would have a reasonable thing that, okay, this patient has been on antibiotic for long, but he is not improving, or he is not showing any signs, or he showed initially the signs, but he is now worsening again. In those cases, you start thinking beyond bacteria, and those situation would be you start looking for a fungus. When do we, on the same line, think of viruses? When these two both are covered and the patient is still going down, and you know that his immunity is very pathetic. You need to have very, very bad immunities, particularly in HIV patients, chemotherapy patients, MAB therapy patients, where it's your immunity is completely destroyed. Then you can also think of virals or antivirals, particularly cytomegalovirus or herpes virus. So in increasing order of the immunosuppression, you can suspect the involvement of the fungus. There is one more situation where you can also preemptively think of fungus. These are the intra-abdominal sepsis, especially secondary or tertiary peritonitis. These are the two situations where you would empirically add antifungals for this patient. Those patients who has got prolonged plastics in their body, whether it's a PICC line, whether it's a central line, or whether it's a urinary catheter, these are the places where you can think of antifungal and preemptively look for it, send for a culture, and preempt and empirically add. Does that answer the question?
Yes, sir. Yes, sir. Thank you.
Do we have any more questions you can ask now? Sir, I believe no one have any question as of now. So if anything rises, we'll be having a class 3. Thank you.
Some chat has sent two questions, three questions.
Okay. No, sir.
Right. Thanks, Rutraj. Yeah. Okay.
Thank you,
Thank you,
sir.
guys. We will be continuing in the next one. I'll try to pick up a few antibiotic adjuvants, which is something which you guys need to know. And then we will go to infection specific ones like tuberculosis, and then we will have all sorts of zoonotics ones coming up. All right. So you can ask your guys, friends who are, if you like the session, you can ask the friends. They can join irrespective of MRCP coaching is going on or not. All right. Thanks, guys.
Thank you, sir.